Welcome everybody to Maternal and Infant Health Canada's educational webinar series. Today we are joined by Dr. Kranti Suresh Vora, who will be discussing experiences working with the tribal population for reproductive health. I'm recognizing a few faces and I'm also seeing a few new names. So welcome everybody. For those of you who are new, or those watching our recording, I'd love to tell you a little bit about Maternal and Infant Health Canada. We are a global health collaborative working to improve the health of women and children around the world while seeking equity-driven solutions to a more sustainable world. This is achieved through education, research, and innovation pillars. We are made up of doctors, researchers, public health professionals, and traditional medicine practitioners from around the world. Our education webinars are co-sponsored by the Global Women Health Network, who are alumni of the Harvard Takemi program in international health. If you'd like to keep up with what's happening at Maternal Infant Health Canada, you have a lot of different ways now. So you can follow our Facebook page. That is in the link in the chat box. We also have a LinkedIn page. We also have, if people are better off with WhatsApp and you'd like to connect with us and get reminders of when the next webinars are, you can email us at MIHCAN, C-A-N, cares @gmail.com. So mycancares@gmail.com, and give us your WhatsApp number and we will add you to that list as well. If you would like to see any of our recorded webinars, including reviewing this one, if you would like to see it again, it will be up on our website, which is maa.med.ubc.ca. And then if you want to go to the webinars, it's /webinars. All right. So we'd like to keep you informed for the future. We have 6 webinars a year. Every 2 months, we host a different speaker. So go to our WhatsApp list or just keep a tab on our Facebook and you'll be able to see when the next one's up. Following the webinar, there will be a questionnaire, a very short one. So we'd love to hear your feedback on the presentation and our work. If you have a minute afterwards, please fill that out. That'd be great. As with all of our public webinars, I must add the following disclaimer. This course and handouts may contain general information about medical conditions and treatments. The information is not advice and should not be treated as such, not medical advice. If you have questions during the webinar, we have a chat box if you're watching this live. And part of what makes these webinars so wonderful is there is a real discussion, and we really do encourage that. So if you have questions throughout, feel free to write them in the chat as we go along. I will capture them, and then at the end of the lecture, we'll allow some time for questions and conversation. As usual, I'm your moderator, Dr. Emily Solomons. I'm a doctor of traditional Chinese medicine and a MIHCAN team lead. I am zooming in from the ancestral and unceded lands of the Coast Salish people, and also known as New Westminster. We also have Dr. Farah Shroff, who I think will be coming in and out as she's in Argentina. Her internet isn't great. And Dr. Shroff is the founder and lead of Maternal Infant Health Canada, as well as a Takemi Fellow alumni at Harvard University. Our distinguished speaker today is Dr. Kranti Suresh Vora. Dr. Vora is an obstetrician turned public health professional. She received her medical degrees from MBBS DGO and an MD from BJ Medical College. Dr. Vora did her Master's of Public Health at Johns Hopkins University, or School of Public Health, and her PhD from the University of Maryland. Dr. Vora received the Bill and Melinda Gates Scholarship for the Master of Public Health and International Teaching Fellowship at the University of Maryland College Park. Currently, Dr. Vora is a professor at IIPHG, so you'll have to explain where that is. Her areas of interest include reproductive child health, health policy, health system strengthening, implementing research, demographic surveillance, health innovations, and cancer research. So without further ado, I will pass the focus on to Dr. Vora to share their presentation on experiences of working with tribal population in reproductive health. Thank you so much for attending.
Thank you, Emily, and thank you everyone for joining in. It's a little late for people in India, and it's early for people in Canada. So thank you so much for joining. IIPHE is Indian Institute of Public Health, Gandhinagar, and we are the first public health university of India. Since 2015. We've been operating since 2007, but we got university status in 2015. And we work with international partners, developmental agencies, universities, etc., especially in the Western India. And we are part of PHFI, which is Public Health Foundation of India. I'm going to talk about experiences of working with tribal population for especially reproductive and child health. And I'm going to share with you some of the projects that we did in the area, and our experiences of that, and then what was the satisfaction or experiences working in those tribal areas. So the objective of presentation is to understand the marginalization of the population that we are talking about. And then, as I said, using the projects that we did, challenges of working in tribal areas, and the satisfaction or the experience of working. So I just wanted to make sure that everyone understood when we say, or when I say tribal population, what exactly I mean. So when Indian Constitution was created, in that, tribal communities were recognized as scheduled tribes. So we keep on using, if you have read papers on India, the acronym ST, which is scheduled tribes. And they are recognized by their characteristics of primitive traits or in distinct culture. So I'll give you an example of a tribe in Gujarat where they hunt monkeys, and that's what they eat. They pick up fruits and other things from the forest, but their basic or the source of food is hunting monkeys, and they live in a deepest part of forest. They hardly come in touch with the general population. So they have primitive traits and their distinct culture. They live in geographical isolation, and they are shy of contact with community at large because they dress differently, their customs are different, and they are most of the times economically backward. Gujarat is the state where I'm from, and we have the highest ST population at around 15%, which lives in about 18% of geographical area, which means that they are isolated. The tribal areas mostly border with Rajasthan, which is another state in Western India, Madhya Pradesh and Maharashtra. So there is a strip which kind of at the border of the state, which is a tribal strip where there are a lot of dense forest, and that's where majority of these people live. To talk about marginalization of tribal population, the literacy level of tribal population in Gujarat is lower than the average literacy level. And as you can see, there's a significant difference. Because we're going to talk about reproductive and child health, I felt that I can give you some numbers just to show how they are marginalized, not just economically or in the education, but also as far as health goes. So NFHS is 5 was done in 19 and 20, and the data shows that undernutrition among tribal children and anemia among tribal women is higher. And this is not just related to nutrition, genetic issues, especially hemoglobinopathies, which is any genetic condition which leads to lower hemoglobin, is very common in tribal population. And malaria is common in that forested area, so that also leads to anemia, increased incidence of anemia. Fertility rate is very high. The birth intervals are very short, and teenage pregnancy are highest among tribals compared to any other population. Tribal mothers are least likely to be seen by a doctor, whether it is for institutional delivery, whether it is for ANC, PNC, or immunization, and receive ultrasound, even one ultrasound. And newborns of tribal mothers are least likely to be seen within an hour of delivery. So the picture that I'm painting is that the utilization, access to care, even basic institutional delivery or neonatal or newborn care is very limited. Under 5 mortality among tribals is almost double the general population, and tribal women are least likely to use sanitary pads. Good news, tribal mothers are more likely to breastfeed. They are more likely to exclusively breastfeed for 6 months. They are more likely to avail financial benefits for delivery care, especially there are some, we call them schemes in India. So there are different ways that government tries to support or give financial benefits to tribal population, and availing of financial benefits is reasonably good. Tribal children are more likely to be vaccinated than general population, and as a lot of tribal communities are matrilineal, sex ratio is better. So as you all know, Southeast Asia, the sex ratio is seen other way around. Per 1,000 men, how many women you have. So that sex ratio compared to general population is better for tribal women. I have put in some pictures just to show, in addition to what I'm saying, just to showcase some of the things that are happening, good or bad. If I have time later, I may explain, but right now I wanted to finish what I wanted to talk about. I just wanted to give you an idea about the marginalization socioeconomically, health-wise, what the definition of tribal population. So now I'll talk about projects. So I'm going to talk here about 3 projects that we did in tribal districts of Gujarat, and they are all different from each other, but it was interesting to work in certain areas. When I say areas, it is aspects of reproductive and child health in the tribal population. So the first project that I'm going to talk about was called MIHCAN project, which was funded by EU FP7. The main recipient of money was Karolinska Institute, Sweden. And then we had a partner in India, Adigadi College in Ujjain, Madhya Pradesh. And IIPHG was the other partner in Gujarat. And basically, the project wanted to evaluate a public-private partnership for improving comprehensive emergency obstetric care. And we had 3 project districts, and out of that, 2 were tribal, Sabarkantha and Dahod. This project is little old, and now Sabarkantha has been broken into Aravali and Sabarkantha. Aravali is a new district that has been carved out of Sabarkantha, which is predominantly tribal district. So in this picture, I'm trying to show what the scheme was or the partnership exactly like. It was called Chiranjeevi Yojana. Chiranjeevi means long life. And the idea was to reduce maternal mortality. So there was accreditation of private obstetrician who would be given upfront some money for conducting 100 institutional deliveries. And the recipient or the target population was women below poverty line and ST or scheduled tribe. And they could go to this accredited private emergency obstetric care provider and receive delivery care free of cost. Out of this 100 deliveries, it didn't matter whether you did cesarean section or normal delivery. You would be paid same for any delivery, and it would be paid lump sum for 100 deliveries. So that is how it worked. One of the reasons why these districts were chosen was because institutional deliveries were lower than state average in this districts, and public sector did not work very well. But at the same time, private sector was also limited. So government wanted to increase access to emergency obstetric care. What we saw was that although the public-private partnership allowed all tribal mothers to be delivered at a private hospital or accredited private hospital free, the uptake was low. And the reason for low uptake was lack of awareness, not knowing where to go. Some of the doctors were reluctant to provide care to tribal mothers. To reach the facilities, they had to pay some money. Sometimes they didn't have that kind of money. And there was also fear of going to a private hospital that they may demand money, and the family could go bankrupt because of the expenses that they have to incur. This is a GIS mapping that we did to show the changes in availability of comprehensive emergency obstetric care. I'm not sure if I put the cursor. Can you see the cursor if I move it?
Yeah, I can see it. Looks great.
Yeah. So the first one is all red. Red means the accessibility is very low. Green means that accessibility is good, and yellow means that there is some accessibility, but not enough. So if you see here, this map is before Chiranjeevi Yojana was implemented in Sabarkantha district. So you see there is this yellow here, patch here, and then one more yellow patch there, but rest of it is all red, which means that overall access to emergency obstetric care or comprehensive emergency obstetric care was very limited. So from there, when Chiranjeevi was started in 2005 and 7, you can see that it went yellow a lot, many places, green, light green in many places. So almost all of the district is being covered except for this area, which is adjacent to Rajasthan. And there was dearth of private sector here. And one other reason was lack of safety because of a dense forestation and very high tribal population. So this area is left out, but rest of the area became green and yellow. So accessibility to free comprehensive emergency obstetric care increased. This is 2012 and 13 data. So during this time, many doctors or obstetricians in because they wanted to protest against PCPNDT. Those who don't know, PCPNDT is a act to reduce prenatal sex selection. It's a law in India that if you do, as a doctor, if you do prenatal sex selection, tell the parents the sex of the unborn child, then you could go to jail or your USG machine can be seized. So in protest of PCPNDT, a lot of obstetricians left Chiranjeevi Yojana. They decided not to participate in Chiranjeevi Yojana. So we have this map where a lot of people left. So if you see, compared to this one, this is less green or yellow area. But overall, the accessibility didn't go back to what it was before Chiranjeevi Yojana. So this basically shows that it was successful in increasing geographical access to comprehensive emergency obstetric care. We covered about 7,000 plus women. Out of that, we had about 3,000 mothers who were Chiranjeevi Yojana eligible, which means that they were either below poverty line or they were tribal mothers. About 1,200 odd mothers delivered at Chiranjeevi facility, and 800 some mothers got the beneficiary or they got benefits of Chiranjeevi, but actually the money which was received from government was only 11.7%. The reason I have this slide here is, one, less than half of the mothers delivered who were eligible delivered at Chiranjeevi facility. So that shows low awareness and reluctance to go to the private sector. Even if they delivered at Chiranjeevi facility, about 50 to 60% were declared beneficiary. And one thing which was very interesting done by the doctors or obstetricians who had private facility was that they would take money from the mother or the family and tell them that when we get money from the government, we'll give your money back. And that way, only 11.7% said that they got their money back and their delivery was almost free. So despite increase in geographic facility, there were issues in implementation of the overall scheme. I could not, I was tempted to put this slide because if you look at Mexico and other places where you have public-private partnership for institutional delivery, you see increase in cesarean section. So we compared two states here. One is there was a Chiranjeevi-like scheme in Madhya Pradesh. Our counterpart RD Gadi did this survey where they saw that after implementation of the scheme, the cesarean section rate went up. It became really high. And this is both the blue lines are Madhya Pradesh cesarean section rate. So if you see, the average is around 5%, but within JSAY, it went through up to 40%. So it skyrocketed. But if you look at Chiranjeevi, both the lines are running almost parallelly and near to each other, between about maybe 8% or 6%. So because of the package which was given, that 100 deliveries, you get this much money, irrespective of whether you do cesarean section or you do normal delivery, made sure that cesarean section rate did not skyrocket. While in MP, there was differential payment. So if you did cesarean section, you were paid higher compared to normal delivery. So this is another thing, a good thing about Chiranjeevi Yojana, increasing geographic access and making sure that the cesarean section rate did not skyrocket. So if I have to summarize our findings from there is that there were 90% AMC visits within tribal women, but the postnatal care visits were only 24%. Obstetric complications, which are self-reported, were found to be about 7%, 83% institutional delivery, but out of 72% eligible women, only 43% delivered at Chiranjeevi facility. And some of the reasons that were given why they did not get the benefit was they did not have documentation when they went for the delivery, or the doctor denied to provide the benefits to that. And this is one of our data collector or surveyor who's going to the home of the woman to collect data, and there are young boys who are curious about what she's doing on the tablet collecting the data. Experience of working for this project, there were many houses which were far-flung and in the farmland and not within the village. So the coverage was, they were delayed because of more time required, but also safety of the girls was also another thing that we had to think of and make sure that they were accompanied by a male person when they are going to far-flung places in the forest. Majority of the women, including pregnant women up to almost third trimester, they worked in the fields. So availability at home was for very limited time. And most of the times it was in the evening. So we had to make sure that we were there at appropriate time to collect data. Interestingly, everyone in that district, wherever we went, all the villages, all the households, they were very welcoming. They were very trusting. And a lot of our data collectors and the girls told me that they would regularly make sure that they had lunch on time. They would invite them in their houses to eat, to rest. Sometimes if they feel that she should not be going at some place on her own, they would accompany. So they were very welcoming and they treated them like family. Ashas were very active in tribal areas compared to other places where we have worked, and they are very cooperative. House listing and everything was made very easy for us. And of course, the surroundings were beautiful, as you can see in this picture, especially during the rains. The second project that I want to talk about is prevalence study that we did for cervical cancer. And it was funded by DST, which is Department of Science and Technology. And the idea was to know the prevalence of HPV and understand acceptance of DNA-based HPV as cervical cancer screening. We worked in tribal areas of Meghraj and Modasa, which are both tribal blocks in Aravalli district. As I told you, it is carved out of Sabarkantha. And we also worked in urban slums of Ahmedabad, where a lot of tribal people come as migrants to work in building sites and other places and stay there. So interestingly, in tribal areas, we had only 25% of the eligible women coming forward for screening, while in urban slums, almost 50% of women came forward for getting screened for cervical cancer. I wanted to show a little bit about what we found in high-risk HPV. So if you can see here, in the tribal areas, about 30% of women had high-risk HPV type, which means that if you have long infection with such virus, you can develop cervical cancer. So almost 75 to 80% of cervical cancer are because of human papillomavirus, high-risk human papillomavirus. So majority of the women had that in tribal area. Similar numbers were found in urban slums also, that about 32% of the women had high-risk HPV. The difference here was that majority of the women or high-risk HPV were 16 and 18, which are very commonly seen and cause cervical cancer. But we also saw that about 17% in urban slums and 12% in tribal areas, there were high-risk HPV which were other than 16 and 18. Why is this important? This is important because India is embarking on nationwide immunization against HPV with quadrivalent vaccine, which is 16, 18, 11, and one more low-risk HPV type. And we need to have some baseline data to know that by giving this vaccine, we will be able to prevent cervical cancer in this population. But still we have this population who can develop cervical cancer because they are not vaccinated against the strain which are not 16 and 18. So this has very important implication on vaccination program and how we envisage the changes that would happen in cervical cancer prevalence. The experience is that cervical cancer prevalence is highest in tribal districts. In Sabarkantha, it's #1 cancer among women. It is low. The screening is lowest in tribal areas as access to screening is limited and awareness is very low. We arranged the screening at the doorstep. We went to them and we did screening at subcenter level, which is within the village, with awareness sessions, 2 to 3 sessions with ASHA, with ANM. We ourselves went. But despite of this, only 25% of eligible women came forward for the screening. And this shows that there is a need to create awareness among tribal population, especially to improve or increase proportion that undergoes screening. What we found interestingly was that the women who came for screening were not different from the ones who did not come for screening with regards to education, age parity, age at marriage, or number of children. So to us, it seemed like it was more a question of convenience at that time. rather than me being aware of cervical cancer and coming for screening, and me not being aware of cervical cancer and not coming for screening. We also noticed that some of the women who underwent screening had complaints of white discharge, but majority of those who did not undergo screening did not have any complaints. So they felt that I'm healthy and there is no need to get screening done. The reasons for low uptake were, of course, lack of awareness, not just in the community, but also among the providers. Even the medical officers, ANM, ASHAs, and staff nurses were not ready to undergo screening themselves, and they did not know the protocol of when to encourage women to undergo cervical cancer screening. Government functionaries were not interested because they are not accountable to the government for how many women go for cervical cancer screening in that area. There's a stigma attached to gynec examination because you need privacy, you have to expose yourself, and cervical cancer screening. So some of the women told that if I undergo screening, it is as if I'm inviting the cancer. So that is why I don't want to get screening done. And very few women knew that cervical cancer is cause of death and it can be prevented. Positive side, women who came forward for the screening were very cooperative. They were very enthusiastic about giving us feedback, exit interview, and even for the collection of sample and all, they were very cooperative. Exit interview showed that majority did not feel any discomfort and were satisfied by the experience. And some of the women who underwent screening actually became our ambassadors to encourage their members or their friends or women who were there in community to go for screening. So that was a positive side, and we felt that this would help in increase overall screening amongst these women. The third project that I want to talk about is again funded by DST. And in this project, we were trying to look at prevalence of TORCH complex, which is toxoplasma, herpes, hepatitis, cytomegalovirus, etc. So there's a bunch of viruses and parasites or tropozoites, you can say, like toxo, which can lead to congenital malformation and poor birth outcomes. And we also wanted to see if stress during pregnancy was also a predictor of poor birth outcome. So we recruited about 950 women from tribal district, Sabarkantha again, and we saw that almost 50% were positive for stress by salivary cortisol. With DHEAS, about 176 women were positive. And we also did plasma cortisol and DHEA. And in that, the number of women who were positive was little less. So we were trying to compare if salivary levels and plasma level, which is the gold standard, they compared with each other or not. Prevalence of toxo was the highest amongst all the infections. And we found some of the women having more than 2 infections. And the second highest prevalence was herpes simplex and Epstein-Barr. The lowest prevalence was found for hepatitis B virus. And this is because there was an outbreak of hepatitis about 10-15 years ago in the same district, and there was a campaign for immunization for hepatitis B in that district, and we feel that because of that overall prevalence. And I should tell you that what we did here was we identified DNA of the virus or RNA of the virus within the plasma. So this was not immunological testing for IgG and IgM. This was DNA identification. The experience for the project was that we had a long process to get permission for the government and gathering women at Mamta Day. So Mamta Day is basically one day in in a month or sometimes more than a month, all pregnant women, lactating women, and kids for immunization are collected in one place in the village. And ANC is done, immunization is done, child development assessment is also done. If you see this picture, this is how Mamta Day looks like. There's weighing machine and people are writing up and pregnant women are around. And we found that gathering pregnant women for at Mamta Day for recruitment was a problem, because not many women came, and some of the women who came were not ready to give blood. So that was an issue. At the facility, when we tried, stakeholders were not interested because um, prevention of poor birth outcome is something which is not a priority for the government. Again, difficult areas and scattered houses made it very difficult for the recruitment and follow-up. Summary of all the projects and experience of working in tribal areas is they live in remote areas in hilly and forested places. Illiteracy is very high. There are trying physical environments. Malnutrition is very common. Some of it is because of their culture and eating habits, and some of it is because of the lack of sanitation. There is inadequate access to potable water. Personal hygiene is a problem. Sanitation is again poor there. And polygamy is very common. So I'm talking about connection with the cervical cancer. So they marry young, they have more children, and polygamy is common in tribal people. That makes them more vulnerable to cervical cancer. All this is compounded by lack of awareness, especially about measures needed to protect their health. They are distanced not in the terms of geography, but also culturally. They are very different, and that makes them distant from the medical facility. There's lack of roads and transportation or access to the facilities. There is insensitive and discriminatory behavior by the staff for the tribal because the way they are. And this we saw in urban slums too. There are financial constraints. So there are many factors, socioeconomic and health systems related, which make access to healthcare very limited for tribal people. There have been a lot of efforts by the government, state government and national government both, to improve tribal health. And here I've tried to show some trends. So this is a special school for tribal children, residential school, which is free for them in Gujarat, where they can come and study. They are given hostel also, and they are given different scholarship. Here, water, tap water and clean water is being available to women for potable water and better sanitation. This is a girl who's a tribal girl, and she dreamed of being a pilot, and some government scheme and others helped her to achieve her dream. So there are efforts to improve the situation, but a lot needs to be done before tribals are equal to the general population in terms of health indicators and socioeconomic indicators. Thank you, and I'll stop here.
Oh, thank you so much. It's so fascinating. I really I like to look, every country works with their indigenous populations differently, and we have so much to learn from each other about this and how we are approaching the different communities and supporting them. I do have some questions who have come up, and yes, I invite everyone, you can put on your cameras, you can write questions in the chat area, or you can raise your hand if you would prefer to ask the question out loud. But just to start us off, regarding—
Can I say something? Can I say something before you start? Yeah, so I see Ashish Upadhyay, and he was the one. Ashish bhai, can you turn on your camera? He was somebody who worked with us in MIHCAN project, and the maps you saw Ashish Bhai made those maps. So he's been
Oh,
part of that journey. So he's here. I'm so happy he's here.
welcome. You're welcome to say something. Thank you for those maps. They were brilliant, very clear. All right. Well, if anyone has questions, feel free to write them to either. So let's start off with regarding the cervical cancer screening. What was the primary cause of the healthcare workers being reluctant to get screenings? Was it the same reasons that there was the stigma around having a vaginal exam?
Yeah, so there were two things. One is stigma around vaginal exam, and the second thing, I think they were worried, which was very interesting, that if I go for cancer screening and what if I'm positive, or what if I have cancer? So I would rather not know than to know and get treated for that. So that was another major. So one was the examination, but the other was that I'm happy, I'm healthy right now. I don't want to go and get examined and get to know that I have cancer and then, be unhappy and go for treatment. So that was the major reason.
Okay, so even among the healthcare workers themselves who understand
Absolutely.
treatment.
Yeah.
Okay.
Even medical officers for that matter. Women medical officers, I asked them, I said, I'm already here. Why don't you give your sample? We'll do it for free for you. You haven't undergone PAP or any screening examination. And they would say, oh, not today. Maybe I'll get it done later when you come second time. And they'll find some reason, but they don't want to undergo.
Okay, that's very interesting. What do you feel is the most prevalent cause preventing access to institutionalized care? Is it the social aspect within the tribal communities? Like, is it the social aspect? Is it infrastructure? Is it funding? What have you found of, because you've touched on all of those, which one do you find is the most prevalent thing preventing that?
I think most common is the abuse or the discrimination that they face when they go to facility. So as soon as they know that they are tribals, there is discrimination there, the way they are being treated. So that's, I mean, all other things add up to this, but it's very interesting that they are trying to stick to their culture very strongly, and some of it is good. So it's like US, like you are trying to convert natives into you, rather than accepting them the way they are and maybe getting involved wherever you need to get involved, rather than to make them change completely. So some of their things are really good, and they respect women. Of course, domestic violence and everything is there, but still they respect women. It's a matrilineal society. Overall, women are stronger. So all those things are good. They have home deliveries where they have certain ways that they make sure that it is aseptic and their own ways. So some of the things are good, but because there is this stigma attached to being tribal, that they are primitive or they are caveman like, so that discrimination actually makes them reluctant to go to institutions, especially private institutions. Because public, still they will go, but private, they are very reluctant. They are scared to enter the place.
Yeah, and that makes sense. And even when you said the residential schools in Canada, the term residential school is a kind of we have a lot of trauma around that. And so when you mentioned that the tribal communities can go to residential schools, it made me wonder if that was a voluntary process or if that was a process that was like if the children were.
No, it's most of the times voluntary. It's not forceful, because here you have to understand the idea is not the religious conversion or anything like that. The idea is to make them mainstream. I have my own reservations about that too. Like if they like wearing what the clothes that they have been wearing for generations, and you want them to wear shirt and pant and, look normal,
Mm-hmm.
versus this. So it has, but it's not forceful, and there is no, I think residential school elsewhere were religious conversions and, making them to forcefully convert to something else. Here it is more voluntary. The parents, if they decide they want to send their kids, only then they go.
Okay. Now, Maria Carmona had a question. So I'm actually going to ask you to unmute. Oops, wrong one. Where did Maria go? She was there. There we go. Here. Maria, if you'd like to ask your question, you're welcome to unmute and ask. If not, I will do that for you. Oh, yes. Go ahead, Maria.
Hi, I'm Maria Carmona. I'm from Presbyterian World Service and Development. We do relief and development projects in all over the world, but my particular area is in Asia. So I had the opportunity to travel to Dumka in Jharkhand state last November to visit the Santal tribes and to understand their health needs. So we also visited a primary health center there, and I observed that there was a telemedicine scheme that was being implemented. So I just wanted to ask Dr. Vora if you have any successful experiences with telemedicine that you could share to us.
Yeah, I myself have not been involved in something like that till now. But yeah, I know of telemedicine pilots that are being done in Gujarat and elsewhere in tribal areas. And some of them are successful, some of them are not. So it varies where they are and who's the one who's running it. But as we have experienced, Farah, with our project that we did, that telemedicine has made a huge difference and improved access to healthcare everywhere, including tribal people.
Thank you for that. Thank you.
Oops, we have a couple of other questions. Well, we have, I guess we'll start with, here we go. Priyansh, and hopefully I say that correctly. Please go ahead, and then we'll go to Dr. Andy Ugo after.
Hi, thank you so much. Thank you so much for the opportunity. It's a pleasure to get the opportunity to learn from these invaluable insights. Thank you, Dr. Vora. So I'm Dr. Priyansh Nath. I'm working in WHCC India. So my question was specifically on more of towards the health-seeking behavior. So one question was regarding, so did you face any issues with alcoholism while working with tribal pregnant women? For example, if they use haria, which is like common in Chhattisgarh, or like if or mahua, which is like tribal people who use it, like, or because of which we face difficulties in getting them to have access to healthcare services. That was one question I had. Second was considering that Mamta Day was similar to the Village Health and Nutrition Day. Wondering like if the primary healthcare takers were also actively enthusiastic in attending these, or if not, then even were the tribal people really interested in coming in good numbers in on such days? And if not, then what were the common issues because of which they did not used to come? So those.
Yeah, so about the alcoholism, we didn't see much alcoholism within the women. We did see tobacco addiction. They had a lot of chewing tobacco. Those women used to use it since they were teenagers. We saw alcoholism amongst husbands and some domestic violence kind of issues among women who were pregnant. About the health-seeking behavior and Mamta Day, what we saw was that tribal women found it difficult to come because, one, they stayed away from the village. As I said, they used to stay on the hillocks and farmland. So for them to walk those 5-10 kilometers and come to the village for Mamta Day was an issue. And the same issue was with Asha and A&M, that they didn't want to walk 5-10 kilometers to vaccinate one child or, see one pregnant woman. So those were the problems of getting them, especially tribal women, in the Mamta Day and recruit them for the study. So basically what happened was our data collectors actually had to go up to the house. And in some places, we actually hired motorbike drivers to take them there and, do the survey, follow up and other things that they needed to do. So that is something which needs to be addressed by the government to ensure that this, you see Dangs, you see Aravali, all those places, the population is scattered. So Asha A&M has to walk more to cover smaller population. Same thing you would see in deserts, in Kutch and Little Run of Kutch. So those are difficult places where you need to have a customized model to ensure that access is good. I hope I have answered your question.
Yes, ma'am. Thank you so much.
Thank you. I think I'm going to ask Dr. Ugo. There we go. Please feel free to answer or to ask your question.
Well, hello.
Hello. Yes, we can hear you.
Yeah, I'm basically wanted to ask about the discrimination on the of the rural area, on the basically where she touched and explained. I'm talking about the in respect of if how would they open up if they are discriminated on basically everything. So how would they open up to come up and do the checkup and the stuff and get to find out if they are infected or not? Because most of them, if they are discriminated, they tend to be closer in their own cycle. They don't tend to come out from their own cycle. Basically, that's my question.
Yeah, that's true. It's very difficult for them to gel with the general population or come out there. And as you said, and I also indicated in my presentation, that there is discrimination when they go to the facility. What would be the solution? Solution should be the providers need to be sensitized that behaving in certain ways with them will make them more wary or fearful of coming to the facility, and that would make their health deteriorate more, and they would come to you with emergency situations rather than preventive measures that you can take to address the health issues. The second thing is what everywhere else is being done, that you train more tribal doctors who are similar to the population, tribal population. There is a comfort level there because their dialect is different. Some of the tribes don't speak the language Gujarati. They speak a different language. So to understand the language, to understand the culture, they see someone who looks like them. Those kind of things, if we can do, then that would improve access to care for them.
Okay, thank you.
Thank you. Next, we have Dr. Gupta. Here, I'll get you to unmute, and you're welcome to ask your question, please.
Thank you. Thank you so much, Dr. Vora. And actually, Dr. Ugo just asked the question that I had kind of put in the chat, but perhaps I can request Dr. Vora to further elaborate on it, because I was interested when you said that they have their own practices around, births and ways like medical practices of their own, the indigenous practices. They're different from the mainstream ones, but they do have their own practices too. And so I'm wondering if there are any experiences around developing hybrid experiences where you build on the indigenous practices, but kind of bring in some of the mainstream practices too. So there's some kind of a combined approach to doing, the kinds of medical tests and procedures and things like that. Thank you.
Yeah, so what I saw there was that the traditional birth attendants that were there in tribal, this thing beforehand they prepared. So if they knew that a woman is full term, then they would make sure that there is a separate area which is cleaned up. And, in the
Mhm.
house, there is identification of an area which is cleaned up,
Right.
like sort of birth preparedness kind of thing. And they would, I mean, that much awareness is there that you use a new blade. They may be using the shaving blade, the old sort of, but still there is a new blade which is there is hot water which is prepared. So those kind of things are being done. Immediate breastfeeding, exclusive breastfeeding, those kind of
Mhm.
things. So even in post birth, the sanitation, the new sari is torn for used as a cloth to absorb the bleeding, not old clothes. So, infection like washed and kept separately in a place, like those kind of things. So it is sort of five cleans, but in their own way. It may
Right.
not conform to what we feel is clean, but
Sure.
in their own way, it is clean, this thing. And I saw that what we think, and I know when I was studying that they would put cow dung and on the cord, and they would give honey, all those things I did not see. Maybe it is there somewhere, but so that much awareness and understanding is already there. And I asked them and they said, no, we haven't been, we don't give. So I don't know whether it was in their generation, previous generations were doing or not doing, but at least right now, those who are doing, they said, no, we have never done.
So
Encouragement like midwives, no kallas, no pushing from above, no pressure on the abdomen to deliver the baby. Like midwives, they were sitting there patiently encouraging women and wiping her brows and those kind of. So it was a very what I call, it's a very loving environment that was there, and I felt it was clean enough. I mean, of course you can have questions about those things, but that's what I was talking about, that there are certain things, and she felt more comfortable in there than going to a facility where no one looks at her, and if she has pain and she screams, then somebody will ask her to shut up or give her one and ask her to keep her mouth shut. Why you are having 3 kids? Who asked you to have 4 kids? Those kind
yeah,
of
yeah,
language.
yeah. So I can totally understand why they wouldn't want to go into the mainstream institution. So I'm thinking, wouldn't it make sense to kind of build on the indigenous approaches? I mean, I've even heard my own, even within my own family, which is not a tribal family, but several generations back, that was the way in which the birthing happened. There was a special room made, and place would be very sanitary, midwife and things like that. So instead of having this kind of either or kind of model, I'm just wondering whether there's any effort to kind of combine and bring the two together.
Right now, we are so much after institutional delivery, even if it is a filthy labor table and she gets 10,000 hospital-acquired infection. But we are so hung up on institutional delivery right now that I don't think anyone is going to listen if we say that we need midwives and we need home births, which are monitored properly and connected, kind of.
Yeah, it's very ironic because in Western societies, we are sort of going back towards some of those, or building on some of those kind of traditional practices, because we now know that those are more effective in some ways, but combining it with some of the modern approaches also.
Yeah, that would be really good.
Yeah.
Then we'll stop treating pregnancy like a disease condition.
Exactly. Yeah. Thank you so much. Very interesting.
Thank you. You know what? I feel like you asked all the questions that I had as well. I had, in my mind, I'm going, well, how come we're not, utilizing the traditional birth attendants and then supporting them in a few best practices while respecting their traditional forms of birthing, and as soon as you have that respect, then generally, you get a little bit more openness to other
acceptance and
we've found cost effective wise that it's more cost effective, but those who love institutional birth, we have our ideals, that'll be the long-term goal, right?
Hello everybody. I just wanted to say a quick hello if that's okay, Dr. Solomons. Thank you everybody. I apologize for not being able to be here on time. I'm Farah Shroff. I wanted to just say thank you for this amazing discussion with Dr. Vora. Dr. Vora is a very, very important and pivotal member of Maternal and Infant Health Canada, and she, as you have seen, does incredible work. We had set up to do some work in the communities she's described back in 2020, March. I had my ticket to be in India March 12th, and the embassy closed on March 11th. So that's why we have no updates on this work from the Canadian and Indian collaboration that we had planned to do. But nevertheless, her amazing work continues. Thank you so much for that. I will just say that after publishing a book on midwifery in Canada, I opted to try to have home births for both of my kids. That was absolutely my own wish, to have births at home in Vancouver, Canada. I'm actually right now in Argentina, talking to you from Cafayate, Argentina, another completely different part of the world. But I would like to thank everybody who helped to make this webinar happen. First of all, with Tomi. Tomi, I don't know if you can possibly unmute yourself and just say hello and show everybody your face. You did a huge amount of amazing work, and I would like to really acknowledge and thank you so much for all the work you did with Dr. Vora, with all of us to make this webinar happen. Are you able to just say anything, Tomi? Maybe not for now, but yeah, thank you to them. And thank you to our yogi who is here, Rajiv Kumar. And thank you to Anne Rivington who's here, and Dr. Ashish. And thank you so much to Lori Ann and Patricia for all of the work that you've done. Yeah, these webinars happen with a lot of labor. It's not the same kind of first stage or second stage or third stage, but it's a different kind of labor. And it was all very, very very well done. Yeah, thank you to all of you who came today, and may the racism that exists all over the world against Indigenous communities, including the country I'm in right now in Argentina, all through the Americas, we all have so much that we can contribute to creating better birth outcomes and better human rights for Indigenous communities. Each one of us who are settlers in whichever land we live in have a huge role to play. And it's so beautiful to see that Dr. Vora, just in her short time from her training to today, saw a lot of social change. And that's the positivity of having people like her doing this kind of work. All right, I will sign off there, but thanks.
You took the words out of my mouth. That's wonderful. Thank you, Dr. Shroff. And thank you for your creating this platform where we can all discuss these really important topics and highlight these people like Dr. Vora, who are doing such incredible work to help inspire us to keep fighting, keep communicating, keep sharing, and keep learning. So with that, thank you so much for speaking and sharing today.
Thank you. Thank you for giving me this opportunity.
And thank you everybody for tuning in.
Let's all get that. Yeah, and everybody please unmute and say hello or goodbye or whatever you want to say. It's always nice to see your faces, but I want to just give Dr. Vora a big hand clap. Yes, there's Maria doing a nice hand clap. Thank you, Maria. Yes, that was amazing, Dr. Vora. Thank you. Thank you so much,
Thank
Dr.
you so much, everyone,
for being here.
Thank you.
Thank you, everyone. Yeah, thanks. Thanks, ma'am.
Dr. Priyansh. Thank you. Thank you, everybody.
Bye, everybody.
Bye.
Bye-bye. Bye-bye. So great to see you all.
Same here.
Bye, Dr.
Bye-bye.
Andy,
Bye.
all the way from Nigeria. So great to see you. Yeah. Okay, Lisa Lee, fabulous that you made it. Hey, Lisa. So great to see your face. Yeah, thanks for coming. And Linda, Tommy, Dr. Ashish, and thank you.